Okay, quick, short case.
My diagnosis is a 6-year-old female child, right hand dominant, right cubitus varus deformity, probably due to malunited supracondylar fracture, with a normal elbow function without any neurovascular deficit. The
Why
child,
probably? What is the other differential?
lateral condylar fracture.
But then you have examined the child afterwards.
Yes, sir.
So you still have a doubt?
No, sir.
So then, so it's one or the other, because you're presuming that you're presenting a case which you have taken the history and you have done your examination findings. But now you should be sure which one of it is the cause. But you're saying most probably, then means there's another cause. So what is it?
So it could be lateral condylar fracture.
But you have examined the patient. So are the findings of a
diagnosis.
supracondylar and a lateral condyle similar?
Supracondylar fracture. No, sir. It's different. In supracondylar fracture, the
So which one is this?
supracondylar fracture.
So then why are you saying probably? Because you have examined the child and we know that supracondylar causing a cubitus varus and a lateral condylar causing a cubitus varus will have different clinical findings, which you have examined hopefully.
Yes, sir.
Okay, but let's see, because you're going to tell us your positive findings. So we should be sure. If this is following a supracondylar fracture, you should say it. So why are you ashamed to say it? You have examined the child. You know for now. So if it is a supracondylar, it's because of a supracondylar fracture.
What are positive examination findings to support your diagnosis?
First, there is cubitus varus deformity, which is triplanar deformity. There is carrying angle of 15 degree of varus, and the lateral condyle is prominent, and the medial condyle is less prominent, and the triangular bony prominence is are maintained when compared to the other side. And this is the differentiating fracture between lateral condylar fracture and the supracondylar fracture.
Madhusudan, these cases are standard cases. Okay, there is no controversy in the diagnosis or the treatment or the examination. So the examiner is looking basically at how good you present this case. Okay, there is nothing to think about. You have to have that format and just say it like one. Okay, so say it now.
So what are the, besides the supracondylar, what else? You say lateral condyle. What else can mimic the findings like a supracondylar, but it's not a supracondylar which causes cubitus varus? What other type of fracture can cause a cubitus varus? Supracondylar was one, lateral condyle was second, you said. Lateral condyle causes more varus or valgus?
Valgus.
Huh?
Non-union of lateral condyle causes valgus, and malunited causes varus.
Sure.
Yes.
What else?
And medial
there is
condyle injury?
Physial overgrowth on medial side, or physial arrest on medial side, or overgrowth on the lateral side. There could be a cubitus varus.
That's a sequel. But what type of fracture can also cause a cubitus varus besides these which you have mentioned? What other type of fracture? So you said supracondylar, you said lateral condyle.
Go a little
Fine.
lower down from supracondylar. What else do you have?
What other?
Commoner and younger age group.
So distal physial separation, which is not uncommon at a very young age, and that findings will be very similar to what you see with the supracondylar. So yes, supracondylar and a physial separation also, distal humeral physial separation can also cause, and your clinical findings will be very similar because you'll get thickening on both sides. And again, when it comes to the 3-point bony relationship, it won't be disturbed. Yeah. So remember, those are two things which can cause a cubitus varus. Okay. What other findings?
So, and there is exaggerated internal rotation and in the shoulder of 10 degree, and restricted external rotation on the right side.
What test did you do to?
Sir,
What test do you can you show?
Yamamoto.
Can you show it?
Yes, sir. कैसा करना ठीक है ऐसा करो
I don't laugh. You get even more nervous.
क्या हुआ?
कुछ नहीं करे, सिर्फ चेक करे बच्चों।
No, leave it. You can just describe. Yeah.
चॉकलेट्स कुछ है?
Sir, we can do this in two types, like
You do it.
measuring the shoulder internal rotation with abducted shoulder and elbow flex, and causing and rotating the internally rotating in the shoulder, or else Yamamoto classically described this in
Very
forward
good.
bending and internal rotating.
You said there's a Cubitus
ठीक है,
Varus.
सीधा कर लीजिए।
You said there's a internal rotation.
Internal rotation with hyperextension. It's a triplanar deformity.
How much?
Sir, hyperextension of 10 degree and carrying angle of 15 degree and exaggerated internal rotation of 10 degree at the shoulders.
Is there a shortening of the upper arm?
Sorry, sir.
Is there a shortening of the upper
So on the
arm?
lateral margin, there is there is lengthening on lengthening of 1 centimeter as compared to the right, and there is shortening of 1 centimeter on the medial side, and the medial epicondyle has is upper as proximal as compared to the lateral epicondyle.
Any other questions? Shall we go next?
What is Bende's sign? That's one of the things that I always ask. It's a very nice test, actually. And that's devised by one of our own colleagues from Mumbai, Dr. Harish Bende. So what he described is that you have a change in the arc of forearm rotation. So you have excessive supination and restricted pronation. Why? You're talking of an elbow problem, isn't it? A supracondylar fracture. Cubitus Varus is an elbow problem which is occurring above the joint. And we know pronation, supination is happening in the proximal, middle, and the distal radioulnar joint. So what's that got to do with a Cubitus Varus?
So Cubitus Varus can cause LUCL attenuation.
No.
No, it's just
Very,
simple
very
mechanics.
simple test.
It's just simple mechanics. If you understand mechanics of the upper limb, it's very simple to understand. So if the limb goes into varus, then the whole apparent forearm goes into excessive supination because the proximal fragment, the distal fragment is in varus. So that varus causes the forearm to also tilt along with it. And you get excessive supination and restricted pronation. Does not mean there's any change actually in the supination pronation arc. It's just that the arc has changed its orientation because of the Cubitus Varus.
So that's why people with orthopedic surgeons who have Cubitus Varus, they are at ease for putting in screws, and they find it difficult to remove the screws. Because, no, this is true. Because the pronation is extra and supination is restricted.
Extra.
The other way around.
Yeah, supination is extra. So, yeah. So, putting the screw is easier. Removing the screw is difficult. No.
Yeah, so that's an important sign. So in addition to, as you said, right, very correctly, remember that all deformities are multiplanar. Actually, they're not. They're all actually in oblique plane. There's no deformity multiplanar. It's just that we are trying to reconcile oblique plane deformity in the planes that we are accustomed to. We are accustomed to coronal plane and sagittal plane because we take X-rays, AP and lateral. But every deformity is in an oblique plane. So what you're actually finding here is that you're showing us an oblique plane deformity and you're resolving it into these three parameters, saying that there's varus, there's internal rotation, and there's hyperextension. But that is true even for the lower limb. So remember that it's very rare in our body to have any deformity purely in the sagittal or purely in the coronal plane. Almost every deformity in our body is in oblique planes, just like scoliosis. So whether it's scoliosis, whether it's Cubitus Varus, whether it's genu varum or genu valgum, most deformities in the body are in an oblique plane. And because we resolve them into these two AP and lateral planes, we then talk of coronal, sagittal, and transverse planes. But every deformity actually is in an oblique plane. It's in a single plane, right? Which is oblique to all these existing planes.
Two quick questions. What is the cause of Cubitus Varus?
You said she's a supracondylar. So what causes supracondylar to go into Cubitus Varus?
In this case, it is a posteromedial subluxation due to posteromedial displacement post.
So that could be a non-reduced supracondylar fracture. The posteromedial subluxation will, in a reduced supracondylar fracture, Why will you get cubitus
So
varus?
sometimes due to in operative the physis is injured on the medial side,
Okay. Suppose it's not operative.
or if it is open procedure, if there is infective component and there is physical destruction on the side.
The commonest reason is malrotation.
Alright.
If there is no medial column contact, the column depresses and that's why it goes into varus. So it's a rotational problem. So what do you want to do for this child?
Sir,
What do you want to do for?
sir, I would like to radiologically examine the child with
Okay.
AP and lateral of elbow with full length humerus elbow and wrist in the same plane of bilateral side.
Okay.
So first, I would like to this is AP and lateral X-ray of 6-year-old skeletally immature child of right,
Which side is abnormal?
right side, sir,
Okay.
of right and left, and we can see radial head epiphysis as well as medial epicondyle ossification center.
What is likely age of this child? She's a girl child. What is the likely age? Give me a range
So
from,
5 to
from the
6.
X-ray.
5 to 6 according to X-ray.
Okay.
Sir, and I would like to check for Bowman's angle, which is approximately 90 degree compared to the other side, which appears normal. Normal
So
is-
left and right angle seems same here, no? If you draw the angle, they almost look equal. Right?
This is looking like
Draw the angles and measure. It is same on both the left and right side.
an
So
anterior.
where is the
humeral
deformity?
line- Anterior humeral line is falling in front.
On an AP X-ray, where is the deformity? Both the angles are same. no?
So which lines are you drawing? What are the lines we're drawing here?
Sir, humeral axis as well as tangential to lateral epicondyle along the physis of the lateral epicondyle, lateral condyle. And I would see the Bowman's angle.
So what is the use of that X-ray? You have taken this full length X-ray. Now I'm just trying to make a comparison with the previous case. The previous case also we had a genu valgum. So it's again a coronal plane deformity. This is Cubitus Varus. Yours we took full length X-rays and we said without a full length X-ray we're never going to make a decision about treatment. Yeah. So same way there we've got a full length X-ray which is very good I would say. But how does it help you that full length X-ray?
Full length X-ray is better than just viewing Bowman's angle for.
So
for
number one is that
assessment
full
of
length X-ray
deformity.
proper?
Sir,
Is that the one that you wanted, the full length X-ray?
Yes, sir.
Yeah, so the middle panel is not good because there's a rotation. If you see that middle panel, that X-ray is rotated, the right side. So I don't want that middle panel. But if you look at that extreme left X-ray on the right of the right limb, that looks good.
This Bowman's angle appears normal on the left side.
So when
And
you have
this
a
is
full
more
length X-ray, it's like saying
increased.
I have a genu valgum and I have a full length X-ray and I'm measuring anatomical femoral tibial angle. It makes no sense, no? Because the purpose of a full length X-ray is to draw a full length axis then. So that's the advantage of having a full length X-ray. If you have a small X-ray, then you use anatomical axis. But if you have a full length X-ray, the whole purpose of a full length X-ray is to draw the full axis of the lower limb, of the upper limb and lower limb. So what are the axes that you will measure here?
Sir, I would like to take anatomical axis of humerus as well as anatomical axis of radioulnar axis.
There's no such thing. What do you mean by radioulnar axis? Show me that. Show me the points because there are points. There are to draw an axis, you need points.
Tomorrow, dashed angle. Which angle? You
No,
take
so
the
let him
reference?
draw the points. No, show us the points. Which are the points you're going to take? One along the long axis of the humerus. So that's humerus line. That's the humerus line. Then the other line. No, from where? You can't just draw randomly. Where's that line going
From
through?
the center of the wrist joint to.
That's not right at all. That's not the axis of the upper limb. Which is the predominant joint in the upper limb? In the elbow. Humeroradial, humeroulnar, humeroulnar. So you want to measure humeroulnar angle. The radius is immaterial because the radius is for the radio for pronosupination. The key joint there is the ulnar, humeroulnar joint. So the humeroulnar axis, where you want to go the humeroulnar angle. So So that's what you're going to measure on a full length X-ray. So if you don't have the
diaphysial line of,
ulna.
yeah,
Mid-diaphysial line of ulna and mid-diaphysial line of humerus.
So that's a far better angle to use than Bowman's. It's like saying, so for me, the Bowman's angle is like taking an X-ray of the knee for a cubitus, for a genovalgum case, and drawing anatomical axis of the femur and tibia. It's less reliable, obviously. The longer we go, the more accurate we become. The shorter we come towards a deformity, the more likely we're going to have errors. So that's the whole purpose of full-length X-rays. That's why we like full-length X-ray of lower limb, full-length X-ray of the upper limb. When you put that X-ray up, I was happy.
So
Because you can make so much more information from
ask you
that.
one question. Tell me one condition in which Bowman's angle is more accurate than humero-ulnar angle. All of you get the question? So Alric is praising the humero-ulnar angle, agreed. But there is one condition in which Bowman's angle will be more accurate than humero-ulnar. In presence of flexion deformity. In presence of flexion deformity, the humero-ulnar angle cannot be measured accurately. So
Why
there
was the Bowman's angle devised? I think we should go back to that.
Yes.
Why is the Bowman's angle being devised in the first place? Why would you want to measure an angle which is so weird? What is the purpose of the Bowman's angle? Why did it come about? Nowhere else in the body do we have angles, weird angles like this. No? We look at axis, and we're happy. So why is the Bowman's angle come into the picture? Why are we measuring this weird angle between the humeral shaft and the line going along the epiphysis, and the difference between that being the humeral angle? What is the purpose of that angle? It was devised specifically for a supracondylar fracture which has been reduced and it's now in flexion. And now we don't have the access to measure. So how do we know that that supracondylar fracture acute has been reduced? Because you know that almost all 97% of supracondylars are extension injuries. You reduce them in flexion. The minute you reduce them in flexion, besides looking at the shape of the fracture line that they are looking good, how else do we know that it's reduced? So the only way we know it's reduced is by the Bowman's angle. So the Bowman's angle was devised specifically for that purpose. After reduction of an extension type supracondylar, when the elbow is now in flexion, and we don't have the axis of the ulna to decide is that supracondylar aligned well or not, that's the reason why we have this weird angle in place where we look at the epiphysis of the lateral condyle. It has otherwise no other utility. So that's why to me, and that's the reason why, as Taral rightly pointed out, when you have a flexion deformity of the elbow, it's the same point that you don't have the axis of the ulna now to draw a humero-ulnar line. You don't have a full length alignment view of a genovalgum. So then you make do with a short view, and in that flex position, you're using the proximal humerus against the distal humerus to decide if there's varus or valgus, because you don't have the full axis to tell you. So we also know why certain angles came about. They were devised for a specific reason. So really speaking, for a Cubitus Varus deformity, we should not be using Bowman's angle. We should be using the humeral axis and compare with the opposite side. Because we know that everyone is different. Unlike in the lower limb where you have a mechanical axis which is, God has designed everyone to be specific. Exactly the same, collinear and joints parallel to each other and to the floor. In the upper limb, you have some who have got excessive valgus, there's some who have got less valgus, some who are rectus. So you want to match the opposite side. You don't want to make someone who's got a rectus angle and decide to go into valgus.
Why do we have a carrying angle?
So just to clear while swinging movement, just to clear the hips.
I've always found a weird answer because I've never seen anyone walking like this, you know. So
if you go to market and you have to carry a bag full of vegetables, you'll walk like that.
Okay. So what do you do?
looking at that central X-ray, can you comment? Did the child have malrotation? Can you comment on the basis of the X-ray?
So yes, sir. Anterior humeral line is passing in front of the capitulum. So this
So that tells you about the sagittal. What about the rotation?
So rotation
Whose index is that?
teardrop sign we have to take on the lateral side. On the lateral.
Well, the teardrop, yes, is a good clue, but that's more for an acute fracture because once you have an older.
Present sign where capitulum is capitulum shadow is overlapped by overlapped.
Oh, I asked a very specific question regarding malrotation. So how would you assess that on an X-ray?
So diameter mismatch.
It's a teardrop.
So what did he say?
You have a diameter mismatch between the diameter of the proximal and diameter of the distal. Doesn't that give you a clue of rotations?
You see that proximal fragment where it has healed, it is broader than the distal fragment, right? What does that indicate?
Rotational component.
Any idea? Anyone from the audience? Whose index you calculate for mal rotation? Gordon's index. Anybody heard of it? Okay, fine. Just go back and read up. So basically, if there is a mismatch between the width of the proximal fragment and the width of the distal fragment, then it indicates that there is a mal rotation at the site of the fracture. Okay, why would you like to treat this?
So that's very good for an acute fracture specialist. So these are all different parameters you're measuring on a supracondylar reduction. So when you do a supracondylar fracture and you're reducing them, that's when you use all these different parameters. You're using the Bowman's angle. You're looking to see the humero-ulnar line for the hyperextension, and you're using the Gordon's index to indicate rotation. Because remember that you're trying to reduce the supracondylar fracture in all three planes: coronal, sagittal, and axial plane. So for the coronal plane, Bowman's angle. For the sagittal plane, we are looking to see the humerocondylar axis. Normally, how much should it be?
It should pass through the capital. Mid of the capital.
Okay. So either you talk of the humerocondylar axis, which is about 30 to 40 degrees. That means we draw an axis of this and that. The anterior condyle or the lateral condyle or the capitellum has an angle to the shaft of the humerus, which is around 30 to 40 degrees. Either you measure the angle or you measure where does it bisect. It should bisect through the posterior half of the capitellum. So that's telling you on the sagittal plane. And then you look at the coronal plane. If there's a mismatch between the diameters of the proximal and distal fragment, and you see spikes, a spike here or a spike there, that indicates there's a rotational problem. So rotation. So we're looking at reduction in all the three planes. Just as you said, it's a multiplanar deformity, which actually is a uniplanar deformity in an oblique plane.
So you have a now girl child with cubitus varus with 10-degree internal rotation and some hyperextension. What do you want to do for her?
So, since my patient's parents are concerned about the cosmosis, I would like to advise. I would like to proceed with the operative management.
If they were
How
not,
much is the varus deformity here?
Sorry.
How much is the varus here?
Sir, 15 degree.
15. And the other side?
Other side is 10 degree of valgus.
Yeah, so totally that means 15 and 10. That means a 25-degree difference is there between the two sides. Yeah, so that's important. That's something major.
Is that the only reason, cosmetic reason?
In future there might be complications like tardy ulnar pulse very rarely, or
no.
there could be lateral condyle fractures, like more prone for lateral condyle fractures, and there will be posterolateral instability due to LUCL attenuation.
Yeah. So what will you do? So this child you will elect to correct.
Yes, sir.
What components do you want to correct?
Sir, only the coronal plane deformity, since sagittal plane might get corrected with, because it is a flexion arc in the arc of movement, and in rotation will be compensated by shoulder. I would just like to concentrate on coronal plane deformity.
Fair enough. So remember that if it's significant, you want to correct all three because you have the power in your hand. Once you have an osteotomy, you can do what you want with it. But the more you try and correct different planes, the more complex your surgery becomes. Yeah. Of course, with a dome, you can do all these things very easily. But you have to decide for yourself is that how much is each of those components. Remember, again, we always kept saying that it's a deformity actually in an oblique plane, but we're resolving it into three planes: coronal, sagittal, and rotational. So if the rotational component is not much and the sagittal plane is not much, then we just work on the coronal plane, which is a fair answer to say. But if you have a significant hyperextension deformity and restricted flexion, then you should correct that arc as well, because you can say that it'll remodel over time. It's not always true. Yeah.
if this flexion deformity and further flexion is up to 110, what will you do for that child? So child is just 1 year post injury. There is cubitus varus deformity, but the range of movement is not full. What would your approach change in that child? Your advice to the parents would change.
I would like to get the range of movement full before
How?
physiotherapy.
So what leads to improvement in the range of movement? Is it physiotherapy or something else? How long would you advise physiotherapy? What is the cause for restriction of movements? So normally there is a bump, there is callus formation in the fossae, which gives rise to restriction of movements. So how does the range of movement improve with age? As the child grows older, what will happen to the range of movements? They improve, right? We have seen that. What is the cause for that?
Remodeling.
Remodeling. And basically with the growth, the area where there was callus formation, that moves away from the physis and the foci get cleared, and that's how the range of movement improves. So never operate a child for the deformity when the range of movement are still restricted. That is one of the prerequisites for your correction.
Good. Good. You did it well.
Only 2 tips. Make sure that if the child is a little nervous, keep them in the mother's lap when you're presenting. You don't want to waste, suppose examiner tells you, show me this, and she just doesn't cooperate. You don't want to waste that time.
Yes.
And like he brought later, your pocket should be full of
Already given.